Evidence-based rehab of total knee replacements. All right, why the heck are we talking about rehab of knee replacements? Well, if you've been a physical therapist for any length of time, knee replacements are definitely one of the most common surgeries, and they're oftentimes one of the most challenging rehabs. So that knee range of motion can be a huge pain in the butt. It's often scary. You get into around week 8, 9, and then you still have a lot of stiffness and deflection. You're calling the doc up. You're trying to get that thing back as much as possible. You're afraid it's going to scar down. There's a ton of swelling. Your quad doesn't work. Patients are in pain. It's kind of a big mess. Knee replacement surgery is also one of the most common questions I have from students when they have patients where they feel like things are going south. So for these reasons, we think it's really important we just give you an evidence-based guide on how to rehab these.
So today we're going to go over a bunch of things related to total knee replacements. We're going to go over, are patients satisfied with long-term outcomes following a total knee replacement? We're going to talk about what's important for recovery after a total knee replacement. We're going to go over the sad fact that there's a lack of consensus and there's confusion around best practices when we look to the research. We're going to review a 2016 article for rehab guidelines following a total knee arthroplasty. It's a good review paper. And then we're putting it all together with a guide of best practices for physical therapists.
What's going on, guys? My name is Dan, and this is Kevin. We are physical therapists, champion PT and performance. We have helped to make thousands of incredible coaches, clinicians through our online communities, mentoring programs, as well as courses. Goal of today's video is to make you 1% better.
All right, so getting into post-op rehab today, I think it was important to start with the fact that a lot of patients after these total knee replacements aren't necessarily satisfied with their outcomes. So if you look through the research, if we're trying to find the best way to rehab these things, it's important to know if patients are happy long-term, and if they're not, maybe where we could intervene from a PT perspective. So this was published in the journal Arthroplasty in 2022, and it's titled The Prevalence and Predictors of Patient Dissatisfaction 5 Years Following a Primary Total Knee Arthroplasty. So what the authors did here is they did a study and they reported a 5-year follow-up after a total knee replacement. And what they found was that 12.7% of patients reported dissatisfaction long-term. And then they were trying to figure out why, what are some common factors here that are leading these patients to be dissatisfied. One thing that we see, I think, with just a lot of post-op surgeries, unfortunately, is increased body mass index. So maybe that points to a little bit of an unhealthier population. They tend to be a little dissatisfied long-term. In a higher Charlson comorbidity index. So that's something too. We see it with a lot of different things. When there's higher rates of comorbidities, it tends to lead to a little bit worse outcomes. If these patients have an increased number of other painful lower extremity joints, they might not do so well either. And then they categorized independent risk factors associated with poor outcomes at 5 years. And this included increased number of other painful lower extremity joints as well. Increased Oswestry back index score. So actually having chronic low back pain, a long history of low back pain, can lead to worse outcomes after a total knee replacement. Unfortunately, again, this is one that we see for a lot of different surgeries, but non-white race. So folks that happen to be of different races tend to have a little bit worse outcomes, or they may be a little more dissatisfied with their outcome. And then if they have minimal pre-op function disability, according to the COOS, they also tend to be a little more dissatisfied. So I think what that tells me is folks who are functioning at a high level that may not be the best candidate for a knee replacement right now, maybe they could delay. If they have their surgery too early, they tend to not be so happy with the results. So I think these are all important things to keep in mind as PTs, because these are things we can intervene on or educate our patients about pre-op, and maybe try to pull some of these levers to get a little bit better outcome with rehab.
Yeah, I thought that was actually pretty interesting. The whole comorbidity thing. At first, I thought you were kind of opening up with some of these numbers to help patients with expectations. I think that that's good. And I think sometimes patients have this expectation that they get a surgery and they're 100% pain-free. They never have trouble for the rest of their life. I think that's unreasonable. And what I do find is when the doctor sets them up and just lets them know, like, there's a chance you'll still have pain, a good chunk of people still have some pain moving forward, then they don't have this expectation that something's gone wrong. They don't get quite as mad, right? But I think the second thing you did, which is even better, is that we know that if someone has more comorbidities or heavier body weight, so on and so forth, that's something we can intervene on. So maybe we can actually even help with those outcomes by addressing some of those additional comorbidities potentially. I just thought that was kind of interesting. And the last thing I will say is that 12% dissatisfaction rate was an 87% satisfaction rate. So I looked at that number. I was like, hey, that's not too bad, especially if you like compare it to other surgeries. But yeah, I get what you're saying. Yeah, we want to make sure that we have the best outcomes possible. Excusez-moi, but I've got something pretty juicy for you. Boom. It's an evidence-based guide to knee osteoarthritis. Uncle Arthur comes for all of us over the course of time, and for your patients, it's no different. But if you've got this cheat sheet, then you'll be ready. Let's face it, nobody has time to stay on top of all the papers coming out on a regular basis and make you a really good coach and clinician. Luckily, you have psychopaths like me who love reading through this stuff, summarizing it, and putting it into a nice little cheat sheet. And my promise to you is I'm going to catch you up on the latest research in under 10 minutes. We go over prevalence, weight loss, risk factors, whether or not competing in a sport increases rates of osteoarthritis, and whether or not strength training slows down the rate of arthritis. We go over pathophysiology, clinical presentation, diagnosis, rehabilitation, and management. Best of all, this thing is 100% free. I'll leave a link in the description below. Go ahead and click on that and get up to date on your favorite knee injury, good old arthritis. Now, back to your learning.
Yeah, and I think just quick, I know a lot of surgeons don't do surgery on certain patients because of those comorbidities. So you might have someone who's, super obese or type 2 diabetic. They might just not do the surgery because we don't want poor outcomes and we don't want the person to be more upset that they don't feel good after. So, and then here's another interesting paper just on the same theme here of trying to figure out where we can maybe do a little bit better job, like Dan said, educating the patient beforehand on realistic outcomes, or if we can do a bit better job solving some of these things to get better outcomes. So this was also published in the journal Arthroplasty in 2023, and it's titled, Are 20% of Patients Actually Dissatisfied Following Total Knee Arthroplasty? A Systematic Review of the Literature. And I think around this time, that number was floating around quite a bit, 20%. So they wanted to dive in and see, is this really true, or where are they getting this number from? So what they found was that the average rate of dissatisfaction is actually closer to 10%. So that's a little bit more in line with what we had just talked about. And if you exclude complications from the surgery, like an infection or something with the hardware, something intraoperatively that's going on, that number of long-term dissatisfaction is a little closer to 7%. So like Dan said, 93%, if we flip it to a more optimistic view, is pretty good. And we could try to figure out what good things we're doing and keep doing to get those satisfaction rates even higher. And then they try to categorize what's leading to dissatisfaction. It looks like folks that are getting these done at a younger age, a little bit higher rates of dissatisfaction. And I think that just speaks to what the prior study was showing, that if you're functioning at a higher level, maybe there's a correlation between a younger age and higher function, that maybe this is someone who we could delay a knee replacement for. And we make sure that we're treating the person and their function and not just the image of arthritis, because they might do a little better if we wait a little bit. Having a lower income, and again, that non-white race seems to be a little bit higher rates of dissatisfaction. Other pre-op factors associated with dissatisfaction is lower Kellgren-Lawrence scores, having anxiety or depression, and pain catastrophizing. So some of those centrally sensitized folks, probably not the best time to do surgery until you maybe get a grasp on that. And then other post-op factors associated with dissatisfaction are complications kind of in surgery. Like I said, if there's an infection, something wrong with the hardware, that's not going to be good for their satisfaction long-term. If you don't meet their expectations. So I think it's important to set realistic expectations, like Dan was saying. If you do have a lot of comorbidities, or you're not in the best health before the surgery, it is important to have that discussion of what's realistic. And then if you do have realistic goals, the patient has realistic goals, coming up with a plan to meet those expectations will be important. And then if they have persistent pain and stiffness, which is one I really think we can intervene on as PTs, then that leads to higher rates of dissatisfaction. So, that's a big one that I think we could focus on. So continuing here, what's important for recovery after a total knee replacement? A systematic review of mixed method studies. So this was a 2024 paper that I thought was pretty good to set the stage of figuring out what is important, what should we focus on for recovery of a total knee replacement. And the study's aim was to identify aspects of recovery that are important to people after a total knee replacement. It's always good to get the patient's perspective. Like, what do they want? What's the point of having this surgery? And it included pain, function, and return to activity. The studies included, there were 23 mixed method studies with over 8,400 participants. So a big cohort of these mixed method studies. The review articles in non-peer reviewed publications were excluded. So those weren't included in this study. And the participants had to be greater than or equal to 18 years old with primary total knee replacement. And the reason for the total knee replacement was osteoarthritis. So I think 18 is kind of funny. Hopefully there's no one with severe osteoarthritis at that age needing a knee replacement. But I think sometimes we do see like traumatic injuries and younger folks do need a knee replacement. So they were trying to just exclude those people. So we're looking primarily at folks getting knee replacements from osteoarthritis. And the key findings, they identified 18 themes that were important to folks for a good outcome. What did they care about? And some of the ones included were pain. Pain was a big one. That was the most important thing is trying to get pain under control. ADLs, mobility and walking, recreational activities, specific functional movements of the knee, use of walking aids, sexual activity, and range of motion. These were the top cited ones that people cared about and reasons that they sought out getting a knee replacement. So again, I think the theme here is keeping these in mind. These are things that are important to patients. So these are perhaps things we want to talk about and address in physical therapy and try to get a capture on how we can make the patient a little bit better at these things or feel a little bit better. Yeah, lastly, I'll just say this is a big part of the collaborative decision-making process with the patient. So sitting down and having these conversations and coming up with a game plan. This study did a good job showing what these patients care about. And we're trying to go together and make a good game plan for a successful post-op rehab.
Yeah, good stuff, Kevin. I think sometimes as physical therapists, we have a patient that comes in post-op total knee, and we're like, okay, let's start going through the, range of motion. Let's start working on strengthening. Let's do all the things we know are beneficial for these folks. But it kind of comes back to the idea of what are the patient's goals? What do they want to get back to, right? I think sometimes, maybe this is not the case for everyone, but when you have a post-op patient, oftentimes there's not a lot of discussion about what folks are trying to get back to or what they want to get out of physical therapy. It's almost like for post-op patients, we have this script. It's like, we know what we're doing. Let's get going, right? We have to do this, to this stage, this stage, this stage. It's not as much of like, all right, what are your goals? How are you doing with your goals? How do we keep on working towards your goals? And maybe that's not for everyone, but sometimes that does feel like what might be going on. So I really like that you're looking at what the majority of patients deem to be important, so we can basically set up our protocols to enhance that, And one of my wonders is like, is something like kneeling included in that list, right? Because one of the things that I'm told frequently for post-op total knees, I was like, have you ever kneeled on that thing? They're like, no, I didn't know if I could. It's like, how you live in your life? You never get down on the floor ever, right? So I can see how a lot of these functional movements, if not considered and worked towards, would definitely make patients a bit dissatisfied because you're not able to do what you like to do with your life, right?
Yeah, and the other thing I'll say with that is I think we could think about it in another positive light too, because a lot of times we're educating these patients on what they can get back to long term. And I know from like a previous podcast we did, folks might want to know, like, can I get back to tennis? Can I get back to running or jogging? And they might think that, they have friends or the surgeon might have said you can't get back to those things. But I think that's a good time to tell them that, we've looked at some of this research and these are realistic things to get back to if the rehab goes well. So, they don't have to quit all of their activities because they've had a knee replacement. it is realistic to get back to higher level activities. So I think some of that is important to educate on before the surgery too. And then here's another paper. This is from 2024, and it's Rehabilitation for Total Knee Arthroplasty, a systematic review. And what I was looking at with this paper was trying to find good protocols, trying to find good recommendations of what we can do as physical therapists. And I thought this was pretty wild because it's such a common surgery. We see this all the time. We see total knee replacements. Like Dan said, if you work as an outpatient physical therapist, I'm sure you've seen these. You might have more than one on your caseload, and you kind of look at the research. And this is a very new paper from 2024. And basically, what it was saying is there's a lack of consistency across studies, raising the question: does physical therapy truly help after a total knee arthroplasty? So it's kind of crazy. And it was hard to find good papers with good recommendations. A lot of them seem to say, like, yeah, PT seems to help, but what exactly should you do? Well, there's so much variance study to study. It's hard to come up with a definitive conclusion. So in this paper, at least, they were trying to answer that. They were trying to find out what does help with physical therapy. What can physical therapy do to help these patients? And they were trying to determine comparative benefits and harms of rehab. So can rehab actually make people worse? In patients undergoing elective unilateral total knee replacement for primary OA. And this review included 53 studies. These were mostly randomized controlled trials and high quality non randomized controlled trials. The study included about 11,500 patients, and the studies measured patient reported, performance based, or healthcare use outcomes. And getting into the results, and looking at the results, it was unclear which rehab program was best or what aspects of rehab are most effective. They had low quality evidence that different rehab types produce similar outcomes for pain, range of motion, and function. So, that's kind of crazy. So different rehab approaches all have similar outcomes when they look at this study. Early rehab may increase strength long term. Later rehab doesn't seem harmful. So these are pretty funny findings. No meaningful difference in satisfaction or quality of life based on rehab timing. So whether you start rehab right away or you delay a little bit for the first few weeks after surgery, it didn't seem to make a difference when they pulled all these studies together. They did note that there were some gaps in evidence. There was no subgroup analysis. So they don't know who benefits most from rehab. They were trying to figure out, who should have rehab after this and who would benefit most. As a PT treating these things, I guess I'm biased, and I think everyone should have physical therapy after a total knee replacement. But they weren't able to answer that. So I think that's still what I would go with. Not enough evidence on whether rehab reduces the need for future procedures. So they weren't able to conclude if you do physical therapy after your total knee replacement, does it reduce the need for a revision surgery down the road, or does it reduce the need for a further procedure? They weren't able to come to that conclusion looking at these studies. So these authors concluded that the evidence is too weak to guide best practices for total knee replacement rehab. A systematic overhaul is needed. Standardized rehab programs and common outcome measures are needed. And why does this matter to us? Well, if we aim to standardize total knee replacement rehab, this paper highlights a major problem. There's current research leaves us with more questions than answers. We don't have a great idea of what these patients should be doing, who will benefit most from PT. And I do think it is pretty crazy because we have so many total knee replacements done each year. I thought there would be a nice paper from 2024 or maybe even 2025 on best rehab practices after total knee replacement. But as the author said, it kind of leaves us with more questions than answers. And I guess the last thing I'll say is, and I know our boss Mike Ronald often says this, is if you pull together a bunch of studies with kind of poorly designed studies answering a bunch of different things, these systematic reviews just become a little bit more confusing. And I kind of feel like that's what this paper was leaving me feeling. So, before we talk about this, I will give hope that another paper that I'll talk about was from 2016 that we'll get to in a minute, that has more definitive guidelines. So I kind of wanted to go over that. And then I will talk about using that paper's guidelines and some of our expert opinion on how to actually develop a post-op knee replacement protocol. But I think it's important to set the stage that the research isn't exactly super clear on the best practices for total knee replacement rehab.
Yeah, it's kind of crazy, I feel like that these results are kind of both sad and kind of hilarious. And like having just delved into literature for a lot of different things over the course of time, I'm not surprised, right? It's like the numbers are staggering in terms of how many knee replacements are performed worldwide. And it's always funny to think. And it's like, we should know what is important from a rehab perspective or whether or not we should be rehabbing these things. And I'm biased too. And, obviously I like physical therapy, but I'd be curious what happens if you let these folks just go and don't do any rehab whatsoever. My gut would say they probably get really stiff, weaker, and maybe they'd have more trouble long term. But if you look at the total hip arthroplasty literature, you'll find that physical therapy doesn't seem to make a big difference for a lot of studies. And what's interesting for me, having now practiced for, I don't know, coming up on 15 years or so, I don't see many total hip replacements, and I haven't historically. And two things. So hip replacements are not as common as knee replacements, right? That's definitely a part of it. And as these studies have come out, I think surgeons see these studies and they recommend less and less physical therapy. And for most of my total hip replacement patients, they usually end up having like a visit or two at the hospital. They go home right away, have some home health, and then they're done. And really, the only patients that I end up seeing are patients that they actually want a little bit more rehab, or they're younger and trying to get back to something that's more advanced, right? And where I think there's a disservice is to those patients that are maybe a bit older and they want to get back to a higher level of function. I think a pretty funny example is when I had a total hip replacement patient, right? And I had treated him a lot prior to surgery. Eventually decided to get the hip replacement, and he was getting back to hockey. I want to say 3 months, right? And he had this like persistent groin pain and hip pain. He's like, I don't get it. I have my joint replaced and my hip still hurt. I'm 3 months after the hip replacement. Why does it hurt? I'm like, dude, you just had a hip replacement 3 months ago and you're playing hockey because no one gave you any guidance on what to do and you had zero rehab. Like, of course it's going to end up hurting. If you have any sort of other surgery and you're trying to get back to a sport and like a hip replacement, there's a lot going on, right? It's not like a very simple procedure where they only poke through a few structures, right? You're chopping bones in half and there's a lot going on there. So it's just interesting to me that we decide that, rehab is the best option. And I think that there is some truth to the fact that some folks probably need more rehab and we need to do a better job of parsing this out, because the folks that don't get rehab that need it, I think are at a disadvantage. It's not fair to them. And then there's probably some folks that don't need much rehab and we have no idea who those folks are, right? But I'm with you. I'm like, how the heck can you get that range of motion back if you just I've got so many non-compliant patients that like basically you don't see them for a while. And then when they come back, their range of motion looks like garbage that you're like, I don't know how you could survive without physical therapy, but who knows? I would love to see the actual outcomes if they studied a bit more, right?
Yeah. Yeah. I think you nailed it. I think that when we look at something like a total knee replacement, that's different from something like Achilles tendon repair or ACL reconstruction. Those folks tend to be younger and they tend to get that injury acutely and they tend to get it from doing a sport. So when we look at what the rehab looks like, we know what they should do and we're trying to progress them back to some type of sport again. I think with the total knee replacement, a lot of folks, if they're pooling all these studies, a lot of these folks are just trying to get out of pain and, or they're just trying to make their knee feel a little bit better. They don't potentially have lofty goals of getting back, they don't have a plan. They just want to get the knee replacement. And the surgeon might say, you just need to get the knee replacement and then, just do a little home PT and then you're going to be fine or whatever it is. And you're right. There's a huge group of patients who want to get back. And that's what we see at Champion is people that want to get back to tennis or they want to get back to golf. They want to get back to some, bike riding or playing with their grandkids. And, I can't see how that's going to be the best outcome unless we sit down and develop a plan with them and try to make sure we're optimizing their function. Again, obviously we're biased, but I think that's what we do best as physical therapists is game plan with the patient and kind of work backwards from their long-term goal. So, I think some of these studies, these review studies just need to be a little bit more nuanced in what patient population they're looking at, and clarifying that. So a PT or a surgeon, more likely a surgeon would look at this and, like you said, think physical therapy, they don't really know what they're doing in rehab. It doesn't seem to be so helpful. According to this review, I'm not sure I'm going to recommend my patients go to physical therapy. I had a bad experience with PTs and my patients in the past. And that's the last thing we need is surgeons thinking that we're not valuable in the rehab process. So, hopefully some more studies will come out that are a little more specific to different patient populations. And then we can really see what the best evidence out there says for rehab approaches.
Well said, Kevin. Hey there, you little learner. Do you like this content and want to go a little deeper with that learning? You should join us with our online community, Insiders Academy. It's our premium subscription membership to help you become a better coach and clinician. We do a lot of good stuff at Insiders. We fill in those gaps in knowledge that school didn't teach you. We go over things like exercise technique and prescription, programming, periodization, strength conditioning principles, and advanced rehab. Let's get you proficient there. We also help to keep you up to date on the latest medical literature, even if you don't have time. And we do this with cheat sheets. And these are PDF downloads that catch you up to date on a given topic in under 10 minutes. And we've got a lot of them, over 50, and we're constantly updating them and adding new ones. It's pretty much the exact same thing as downloading all of our knowledge directly into your own brain. We also keep you up to date with our master courses. We cover pathologies in depth so you know exactly how to diagnose and treat patients with these issues. And we're really thorough, going over prevalence and prognosis, risk factors, anatomy, history, clinical presentation, diagnosis, differential diagnosis, patient education, and exercise prescription, as well as manual therapies. We have a whole bunch of master courses and we're always updating and adding new ones. Some of the big dogs are rotator cuff related pain, knee osteoarthritis, shoulder instability, femoral acetabular impingement syndrome, SLAP pathology, cervical radiculopathy, lateral ankle sprains, and radicular low back pain. Who doesn't love some searing back pain going down their leg? We also include case studies with every one of our courses. This way, you can see exactly how we diagnose and treat. Each master course comes with in-depth protocols, both non-op and post-op. This way, you know the exact exercise we like to use with videos of all movements, how many sets, how many reps, how do the exercises progress over the course of time, what are the relevant manual therapies when they're indicated, and exactly what you should educate your patient about. Hey, are you a physical therapist, athletic trainer, or physical therapy assistant and looking for some CEUs? Well, we got you covered, and you can even earn CEUs for watching the content you're watching right now. Finish up the master course, take the exam, get the CEUs. Easy peasy. With Insiders Academy, you also have community access. Basically, you can have all of your questions answered by me and the rest of our team at Fitness Pain Free. This way, as you go through the learning and you have a question, you'll get it answered. Best of all, you can get started with Insiders Academy for just $1 for a week-long trial. After that, it's $25 per month. If you want to save 2 months, get them for free, then sign up for the yearly membership. I'm going to leave that link with a discount in the description below so you can check it out, and I'll see you there. Now, back to your learning.
So this is that article I wanted to talk about from the journal Knee Surgery in 2016. It's Rehab Guidelines After Total Knee Arthroplasty, a review. And I think this one at least started to give us a little bit of answers, and they kind of looked at a bunch of different exercise techniques or modalities and other things we can do as physical therapists and provided some best evidence for if it seems to be helpful or not. So they searched through all rehab modalities, including exercise, aquatic therapy, balance therapy, CPM, cold and compression, NMES, TENS, and even AISTM, which is something we use quite a bit. And the background is, the author said in long-term results, long-term outcomes for these patients, there's obviously a need for good surgical techniques and good implantation devices and materials. That's something we can't control as PTs, but then also a good part, an important part of the outcome is good rehab. And that's where we can intervene. So it's well documented. I think setting the stage here that quad strength drops. One study cites 50 to 60% after a total knee replacement. And it often never gets back to preoperative levels. And you could think that these patients have had arthritis for a long time. Their pre-op levels are probably not great either. So that's definitely going to be an issue. So I kind of looked at each of these topics that the authors talked about and just summarized the findings of the review a little bit. So for strength training, they kind of concluded that maximizing early range of motion improves strength and pain. So that's definitely something we need to do, and it can help normalize gait mechanics. There's a lack of standardized progressive strengthening programs out there. So similar findings to the 2024. Strengthening is good, but what exactly to do, we're not sure. But we should consider the patient's long-term goals and function. So at least some guidance there. If we are implementing these strengthening programs, there's probably some basics that we should be doing like we do in all strengthening programs. But considering the long-term goals of the patient will be important as well. For aqua therapy, they concluded that it may be helpful for patients who are experiencing a lot of pain. And this is due to the buoyancy effects of water. So we don't have a aqua therapy or a pool at Champion, but I did used to work for a clinic that did. And I know that this can be really helpful for these patients. Usually they'll wait until the incisions are closed and everything looks good from that standpoint. But I think these patients like it. Their knee feels, they feel lighter in the pool. They can get some motion going. Some of the compression of the water seems to feel helpful. So yeah, some studies have shown benefits of aquatic therapy versus standard therapy alone. So that's an adjunct that we might consider, according to this paper. They also get into balance training, and their summary was that some studies show an improvement in post-op function in rehab with balance training. These improvements may be secondary to restoring joint proprioception and postural control, but again, no clear progressive protocol exists. The authors also mentioned CPM, so continuous passive motion devices. Some docs in Boston tend to use these for, we talked about this in a prior episode of the hip, but also in the knee, whether it's ACL reconstruction, we do see that happening a little bit, and sometimes for total knee replacement. And the authors here concluded that while some may argue for the benefits of a CPM in the acute inpatient phase, its degree of long-term advantage still remains controversial. More recent research has suggested CPM use may be associated with increased post-op blood drainage, increased analgesic use, and persistent swelling. So as a result of this new evidence, orthopedists should assess if it will have a positive impact on patient recovery. So, we do hear different things. I think some of these findings seem kind of anti-CPM, but some of the patients we see kind of like it. So we'll talk about that when we talk about what exactly to do after all this kind of gray findings. They get into cryotherapy and compression. Our authors here concluded that most studies suggest that cryopneumatic therapy is effective for post-op pain relief and function. And this might be because ice can decrease the metabolic activity of local tissues, and it has been shown to improve pain and swelling. So I always like ice. Again, we'll talk about this with the kind of summary slides protocol that I kind of came up with. But I think it can reduce analgesic use. It can reduce the use of even NSAIDs that we know could be a little harmful on the stomach. Don't want the patient to, develop an ulcer or anything like that. So, the authors here do seem to be in favor of icing. In terms of NMES, patients who are unable to voluntarily contract their quad after a total knee replacement may benefit from early intervention with NMES. It has been shown to mitigate strength loss in the quad. However, there is a heterogeneity of NMES protocols, which may result in conflicting findings in the research. And they concluded that further research is needed to land on the best parameters for this population. And then the final couple here is with the TENS unit. They said that as a pain relief modality, TENS has been gaining popularity among patients despite the presence of contradictory results in the research. The exact mechanisms of pain relief is more complex than we currently understand, and it may warrant further trials. So again, pretty gray there on what to do with TENS. And then in terms of IASTM, it has been shown to yield positive results in the treatment of tendon and joint pain. Evidence has yet to emerge on its effects on joint stiffness, but the authors of this paper did want to note that they use it in their own practice and they find it very helpful. And we use it as well at Champion and also find it fairly helpful. So, I like this paper because at least they were trying to, look at some specific interventions and give us some guidance on what we should consider doing, what we should not consider doing. But I did find that, again, a lot of it is, yeah, strengthening is good, but what exactly to do, kind of inconclusive. NMES is good, but the parameters inconclusive. So, a lot of that stuff over and over. So what are your thoughts on that, Dan?
It's a lot to unpack. Like I said, I'm not surprised, but it is kind of sad that we have some ideas. I think we have some good ideas. I'm sure you'll go over those, but not a lot of our ideas are well supported. Right? We're not really sure just how good these things actually are. Just basically the information that you had kind of given, essentially the weakness in the quad, right? That's probably due to having so much pain prior to surgery, then having the surgery and the autogenic muscle inhibition. We make a big deal about this in post-op knees from an athletic standpoint. So ACL reconstruction, meniscus, so on and so forth. But a lot of that research is actually in post-op knee arthroplasty as well, right? So early on, one of my thoughts is that you have to be really good with your exercise prescription for the quad. And I think it's for a variety of reasons. So the knee replacement is always interesting to me because it seems to be pretty dang painful, right? I haven't had my knee replaced. So, take that with a grain of salt. But these patients typically hurt a lot. They have a crazy amount of swelling. Of all the patients I can think of from a knee surgery perspective, they definitely have more swelling than anyone else, right? So we're thinking that swelling is related to that inhibition. And another thing to think about is when your whole knee is sitting in swelling, that's going to make the whole knee more sensitive. The whole knee is sitting in inflammatory soup, right? So from a pain and autogenic muscle inhibition standpoint, that's huge. They've got a crazy amount of that. So we have to be really smart with our exercise prescription and our strategies to reduce the AMI. And on top of that, we're cranking the crap out of their knee, trying to improve knee flexion range of motion because of this ticking talk that essentially says, if we don't restore this range of motion fast enough, we're going to end up with a super stiff knee. And I bet you that increases AMI. We're hurting that person's knee every time they come in. And what I like to say is at Champion, we're just big fans of constant frequent motion. We don't like to crank knees necessarily, but this is a population where you have to be a little more aggressive than, let's say, like ACL reconstruction, right? So I just think that we have our work cut out for us. And it's kind of unfortunate that we don't have all the knowledge, but in a lot of ways, I think that a total knee replacement, although it's typically in an older sedentary person who doesn't want to get back to as much, we maybe even have to be a little bit better with our exercise prescription and our application of like AMI type stuff, because we're working against a harder rehab, right? In an older individual, it's a little bit more sedentary and not as robust as an athlete. So being really good with your exercise prescription for the quad, for the rest of the body, being really good with your AMI strategies, being really good with balance, advancement of balance. It's my own personal bias, but just looking back on my history of treating these, particularly when I was in an in-network facility, we saw a million of these. The large majority of my time was mostly centered around restoring range of motion, and I probably did a disservice to improving strength and function and proprioception. But I think the truth of the matter is that you only have limited time with a total knee replacement in any patient to standard outpatient setting. And if that knee flexion range of motion is the big thing you're focusing on, then the strengthening, the proprioception, all the other stuff kind of falls by the wayside a little bit. And I think these patients probably need a very robust program, just like any other athlete that's kind of rehabbing from an injury. And unfortunately, I don't feel like we always do that. It's kind of the nature of the beast sometimes, but.
All right. Yep. So this leads us to wonder, how do you rehab a patient who had a total knee replacement? So we'll try to give you some answers now. So I looked at a couple of the papers we talked about, especially that last one from 2016. And then I was looking at a protocol from the Ohio State University, which I think puts out pretty good protocols, and just tried to, extract some of the biggest themes for each kind of stage here. So had an early stage, a middle stage, and a late stage. Think of the early stage as the first 6 weeks. And kind of the big goal here is to protect the healing tissue. So, educating the patient on using their assistive device. If they do have a CPM, educating them to use that as frequently as recommended by the surgeon. A lot of times surgeons will progress the range of motion in the CPM each day or each week. So make sure that we're kind of going according to those guidelines. A big goal as well is controlling the pain and the swelling. So we recommend regular icing. I'll usually have someone start with icing for 10 or 15 minutes, 10 or 15-minute bouts about 4 or 5 times a day, and then kind of take it from there. I do like to do it with elevation. So I tend to have them lie down and make sure the knee joint is above the level of the heart. In this position, they can do things like quad sets or ankle pumps, and that can help sometimes with the swelling. And oftentimes, these patients are using like a compression sleeve too. The doctors might recommend that they use that for the first, 2 to 4 weeks. I kind of see different things, but they want to make sure that they're preventing blood clots and helping with the swelling. So I know, like Dan had just said, this is one that gets very swollen, can get very painful. So trying to control that early on and just, I think a little less is more in the very early weeks here. The next big goal in the first 6 weeks is starting to regain range of motion. So a few of the different protocols I was looking at want to get to 90 degrees of knee flexion by week 2. I think that kind of starts to set you up for success. If you're really not working on it or you're nowhere near 90 degrees by week 2, you might be behind the 8 ball a little bit. So I think that's a good goal to have. The way we like to do passive range of motion at Champion is have the patient sitting on the edge of a table, and then we're just sitting in front of them in a stool, letting gravity kind of bend their knee for them. We're just controlling it. And this is a nice position because the patient can kind of see what's going on. They feel like they're in control. They see what you're doing. And you can kind of let gravity do its thing. And a lot of times that helps just let the knee kind of drop into a little bit of flexion. I like to follow that up with active assisted range of motion. So maybe a patient is doing like a curl with a physio ball where they're working on their knee bending. I really like heel slides on a wall. So if the patient is mobile enough to kind of get their feet up on a wall, you just let gravity do its thing. You can also use your unaffected leg to try to bend the knee while you do those heel slides. And this is one I've found recently that patients just tend to like. They're kind of in control of how far they go. It gives them something to do throughout the day if they have the time to get the knee bending. As they get a little bit better, I think it works nicely to do like a heel slide with a stretch strap so they can give a little overpressure. That tends to work fairly nice as well. And then, different surgeons might recommend different things, but generally we're pretty safe to start a stationary bike early. And this is a good way to work on motion. You look at those 90 degrees by week 2, you're not going to get all the way around on the bike, but you can set someone up there and just have them rock back and forth. And I think it's fun for the patient when they see how close they get to a full revolution. And as they get closer, it is exciting when they do get all the way around. So this is a nice time to work on that. And again, like the uninvolved side's doing most of the pedaling here. So they're kind of just hanging out the newly surgical leg and just kind of going along for the ride with the little spin. And then doing patellar mobs. So I think that's a big one here too, is if they're not moving a lot for a period of time, we know the patellar mobility is going to get a little stiff. So we want to go ahead and work on that, especially in all directions. It's hard to do when there's a ton of swelling. So I think that's why working on all these things in conjunction is important. As swelling gets better, you get a little bit better purchase on the patella, and you can get a little bit better joint play there. And then by that 4 to 6 week mark, we're looking to get a little bit better extension motion. So I think for a lot of these folks with total knee replacements, extension doesn't seem to be a huge problem, but we want to check in on that and make sure we're really focusing on improving the flexion. But one thing we can do when they're doing all this other work on their flexion motion is just educate them like, hey, if you're home, you're not doing your flexion exercises, you're not icing, consider sitting with your heel propped up with nothing behind your knee. And I'll usually start folks out with like 2 or 3 bouts of 10 or 15 minutes and just making sure that we are seeing that progression of extension, hopefully getting full motion by 4 to 6 weeks. And if we're not there in that dosage of 2 to 3 times a day for 10 to 15 minutes isn't enough, we can always bump that up. So, make sure every time someone comes in, I think the first thing I like to do is measure their range of motion and look at swelling, and then get into the session and get another measurement at the end, and just make sure each session and each week we're progressing a little bit closer to these guidelines. So, a little bit there, continuing with the early phase, that 0 to 6 weeks, is you're setting the stage of strengthening. So one thing we can do that we do a lot of champion is starting with NMES very early on. Like we talked about, we know quad strength in these folks is a huge issue, and trying to get quad strength back is super important for normal gait, normal function, returning to some of these higher level activities. And from that 2016 article, we know NMES can be helpful. We just don't know the exact right dose. So the way that we do it at Champion is we have one of the Chattanooga devices that administers the NMES when the patient is holding the trigger. So we can use it with different types of exercises. And I try to cue getting the highest amount of stim that we can deliver that's not causing the patient pain, but is giving them a visible quad contraction. So I guess the higher, the better. You will see in the research, and I think we learned in school, some of these protocols where you're doing 10 seconds delivering the stim, followed by a 50-second rest. I think that's a pretty traditional one that we'll see in the research. And we have some patients who actually are fortunate enough to have NMES devices at home. So when we're in PT, I kind of like to use the trigger one where it delivers a stim on volition. So whenever they decide to squeeze that trigger. But if they do have access to this is something they can do at home, just hanging out, let the stim contract their quad, and just get regular firing there, I think is good. With the stim, we like to do kind of a four-way hip type thing, standing, even if they're not, comfortable putting full weight on their knee yet. Doing TKEs, I think is good. Long arc quads, just different ways to attack the quads early on. We want to make sure that we're also progressing the ambulation. So a lot of times after surgery, these folks will be using a walker. As their quad strength gets better, they're able to walk better. They don't seem like as much of a fall risk. There are some tests you could administer to check on if they're a fall risk, but we could progress that walker to a cane. And then eventually we're progressing the cane to no assistive device. And a good trick there is usually like in the clinic and at home, we try to work on using as little assistive device as possible, and then just educate them, hey, you look pretty good on the cane in the clinic, but when you're out in the community, maybe stick with the walker so other people kind of know to stay away, and you feel a little bit more stable, or you feel a little bit safer. And then these first 6 weeks, we're keeping in mind some red flags and educating the patient on these things to make sure that none of these things are developing or we're not falling too far behind. So if you're really missing extension by week 6, maybe not a red flag, but something that we want to improve sooner rather than later, because we're gonna have trouble getting back full flexion, and long term you never really get back full flexion compared to the other side, but that's going to be an emphasis, and so is strength. So getting extension back early, I think, is important. If there's significant swelling or you're just not getting a good quad activation by week 6, that might be an issue. And then also you're educating the patient and just making sure there are no signs of a DVT. We know a lot of these folks that have knee replacements sometimes have other comorbidities, and they're probably at higher risk of this anyway. So, that's probably something to check in with each session and just make sure that's not anything that you're going to be dealing with, because that's a huge red flag. So that kind of covers the first 6 weeks. What do you think about that, Dan?
Cool. Sounds sounds comprehensive to me. I just swallowed a frog. Sorry. Let's get that frog out. Yeah, I guess just to rehash, it sounds that the patient comes in, we have to be wary of red flags, right? We have to deal with the swelling, deal with the pain, improve range of motion, and get that quad back on board as best as we can. I do like your setup. I think it's like a very practical application of all this. Could be have your patient come in, if possible, early, right? Throw on some like a free sleeve. We use those at Champion. I think those are great. You just roll it over top of your leg, goes right onto the knee. It compresses it and ices it. And that's probably going to help with reducing some of that swelling, which may help with the range of motion. And it also is probably going to help a little bit with the quad inhibition. And then from there, we can go ahead. Sometimes, and we've done this too, a champion, where you have the freeze squeeze or squeeze freeze. What the heck is it called? It's a freeze sleeve. There we go. Wow, that's tough. And you can have that on your patient while you perform soft tissue mobility. So maybe you have them in prone and you're working on the hamstring and calf, and you can also flip them over into supine and work on the quad a little bit potentially while they have that on. I also like having the idea of having them elevate. So if they're coming 10 or 15 minutes early, you put that on them, elevate the leg, hopefully get rid of that swelling. And then from there, immediately start working on range of motion. After that, throwing on some NMES, trying to get that quad back on board with all the basic exercises as much as possible. One of the things I think we have trouble with is where potentially biofeedback fits into this, right? Because I think that that's another thing that evidence shows may be helpful for folks that have difficulty activating their quad. And I think the other thing that I'll mention is that sometimes I think what happens with physical therapists is there's a protocol they're supposed to follow. So like, okay, we're going to do quad sets, and then we're going to do straight leg raises, and then we're going to do short arc quads, and then we're going to do long arc quads. And it's the same thing I do. But I also wouldn't be fearful of sticking towards exercises that feel a little bit better for your patient, right? So let's say like your patient really feels bad with the long arc quads. Maybe we stick with a short arc or maybe a squat or something along those lines. I do think you have to isolate that, but I also feel like if you're going to choose exercises for the patient, the ones that feel a little bit better and get a better quad contraction are probably okay to double up on and back off of some of the ones that feel not so good early on, just to increase comfort and probably get a better outcome there.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
All right, so getting into the mid stage here, we're kind of thinking like week 6 to 3 months out or so. And what we'll see here in the different protocols is trying to get range of motion to about 110 degrees by 8 weeks. And then you're shooting for 120 plus degrees by week 12. And you know, like I said, I think it's unrealistic for these folks to get their full range of motion, you know, of what the other side might be. You know, say they're at 135, 140. I don't think we're getting that far with a knee replacement. But if we can get to 125, 130, I think that's really good, and something that with most function they're not going to feel a difference. So I'd say a good rule is by 12 weeks you want to have pretty much full motion. So I think that's a good goal to shoot for. And how do we do this? Well, we can kind of continue the early stage approach if needed, and then we progress. Exercise progression through more movement should help improve range of motion. So when we're out in the gym, maybe we're starting like a squatting program, we're doing some deadlifting. That's going to help work on the range of motion because they're using surrounding muscles more. We know that's going to help with swelling, and they're kind of using their body weight to help to get into some deeper ranges of motion. But some other exercises that are helpful to work on motion, and Dan, I definitely got these from you, is having someone put a foot on like a chair or a step, and they're just lunging into that. So it's not a lunge for strengthening; it's a lunge for range of motion. So you put your foot on the seat of a chair, you kind of hold the back of the chair, and you just lunge into it and let the knee bend. Folks tend to like that one because they're in control of how much it's bending. Another one that I think is super, super, super helpful, and you mentioned this too, a lot of times we're like, how have these patients not done any kneeling at all? But I think a good place to start is on the PT table. They're soft. Start working on having the patient kneel on the table in kind of that quadruped or all four position, and then do some quad rock backs. So they're just sitting back towards their heels. And this is a great way to work on range of motion as well. Like they're using their body weight and they're in total control of how far they go. So I'll usually have someone do, maybe 2 sets of 10 reps, but they're holding each rep at the end range for like 3 to 5 seconds. And that's a good one. They like to work on that at home because they're kind of killing, 2 birds with 1 stone. They're able to work on kneeling and they're working on their knee flexion range of motion. So, I think of those as a little further out because folks aren't going to feel great kneeling on that knee too early. But by 12 weeks, I think that's absolutely appropriate, even closer to like 6 to 8 weeks if they start feeling a little better. That's something you can play around with. And then if their quad's getting tight, sometimes they like to do lying on their stomach with like a stretch strap around their foot, just working on prone knee flexion range of motion. And it's nice to hear folks say that, I feel a stretch in my quad. My quad feels really good doing this stretch. If they have a ton of swelling, a lot of times they still feel it in the knee and it doesn't feel great. So I think of that as maybe a little bit later phase 1 to work on range of motion, but that's another tool for that. And then, like I said, that will work on motion is getting in the gym. So the other thing we want to focus on in this phase, aside from achieving full knee flexion, is normalizing strength and balance. So we're going to progress to closed chain exercises, and these become a little more targeted towards the end of this 3 months to the patient's long-term goals. So we're doing things like squats, we're doing things like lunges, step ups, step downs, leg press. We're training the whole kinetic chain. So, we're working a little bit on the joints above and below, probably doing some calf strengthening. Some of those hip accessory exercises from the early phases might be something that we keep in. We can continue with the NMES if needed, but oftentimes it's not needed as much as we progress through this phase. And then we're advancing our balance in proprioception training exercises. I think this is a big one. A lot of times we're working with an older population who might be a fall risk anyway. So hammering some of this stuff, I think, will definitely be important. Like I said, I think the OSU protocol has some good specific examples. And I know Dan's put out a lot of good stuff on Fitness Pain Free and like the insiders for different strengthening progressions and balance progressions and stuff like that. So kind of look to that for, very specific exercises. But I think the phased approach, those are the big things we want to hit in this kind of middle phase.
Yeah, I do have maybe I'll just put that link in the description. There's always like 1,000 videos. I have to remember to put the link in the description after these. But I do have a balanced progression one, which I think is pretty good. One thing I will say is that it does feel a bit like a ticking time bomb, right? And I've had a lot of docs tell me that by the time they get to around week 12, it's basically your last chance to restore that range of motion. And I think this just comes down to tissue healing times and how long it takes to form a mature scar. So the best of my knowledge, you start having an immature scar that forms around 4 weeks. And then when you get to around 10 to 12 weeks, it becomes a mature scar. So the idea is that as your knee is healing, it's getting stiffer and stiffer, which is good. Scar is a good thing. It's an important thing for our body. It's part of the healing process, but it's stiff. So largely you're trying to restore as much range of motion as possible by 3 months. So what I will say is that in that first phase, we have to be careful. If we overdo it, we make things worse. Just because it's so swollen, so irritable, if we push the range of motion too aggressively, we can cause some problems. When we get to the second phase, I think, and I tell my patients, like, it's like you're going to war on range of motion on your knee. And you really do have to treat it seriously. And one of the principles we always talk about is just constant, frequent motion over intensity. So what that means to me is that I'd say 3 to 5 times a day, even up to every single hour, doing exercises to promote mobility. So it might just be as easy as 1 or 2 exercises, maybe seated in your chair. You're doing some overpressure with your opposite side leg, working in flexion. You do 10 or 15 repetitions. If it's extension you need to focus on, then maybe you're propping your leg and doing a quad set. So you're just doing lots and lots of frequent motion, depending on what's limited. We know that flexion is going to be the big one. The other thing I will say is low load, long duration stretching. So usually knee extension is the more important motion for function. If you have a stiff knee that doesn't extend well, that's obviously a big deal from almost all activities, particularly any sort of walking exercises. So if you prop up your leg and then put some ankle weights above the knee and prop up the heel, let's say a half foam roller, just to straighten out that leg, and doing that multiple times per day, try to accumulate a total of 1 hour, can be beneficial. One of the things we have in our clinic at Champion, I used to use this in the old clinic too, is a flexionator. So it's basically a chair that you put your heel into. It's like a medieval torture device, and you crank it and it bends your knee more and more. But you can do some low load, long duration stretching for knee flexion as well. And you can be creative and do it on your own. So essentially, if you just are sitting in a lower seat, you take your knee and you bend it behind you, and you essentially put a little bit of body weight forward so it bends your knee and hold that. Again, you can do, let's say, 3 sets of 20 minutes throughout the course of the day. But if you have a patient that's behind, that's when I generally tend to employ the low load, long duration. So I may prescribe 3 to 5 times per day, doing some constant frequent motion, always measuring the range of motion. If it's improving as well as it's supposed to, we're hitting these parameters, great. If not, let's up that frequency every hour. If that's still not working, I start incorporating the low load, long duration, because once you get to about 12 weeks, it just gets harder. Can you restore some range of motion after 12 weeks? Yeah, probably, but it's just more challenging. So really, you're trying to do as much as you possibly can before that 12-week mark. And then if things are not progressing, sometimes you want to send back to the doctor. I think it's better to get the doctor on board earlier. What you don't want to do is have a knee that's stuck at like 90 degrees of knee flexion, and at 12 weeks, you talk to the doctor at that point, and it's like, well, a little late now, right? And then if they're really not progressing, they consider things like manipulation under anesthesia. I think you recently had a patient that had a manipulation under anesthesia, right, Kevin?
Yeah, she was definitely struggling. She had a lot of comorbidities, and I think like this was her 3rd iteration of a knee replacement. So yeah, that was something that happened, and then it got a little better temporarily, and then it actually got worse again. So I hope she's doing okay. I haven't heard from her.
Yeah, but she also had a bunch of infections and stuff too. She had a lot of uncontrolled variables, I would say. They made it really tough.
Yeah. Getting into the later phases. So this is month 3 plus. So kind of progressing long term here. And what we want to do here is higher level strength and balance work. So we want to progress those mid-stage exercises. I think a good thing to just keep in mind is that concept of progressive overload. So, if we are doing the basics like squats and lunges, just making sure that, maybe early on to get the motor control good, we're doing higher reps, we're doing higher volume, but then we're progressing the intensity and maybe reducing the volume a little bit over time. So I think it's nice to write out like, a 4 to 6 week phase of strengthening, and just make sure each week you're kind of, progressing the load or progressing the sets and reps or whatever approach you want to take. But kind of following a written plan can be good there, so you don't get lost in the rehab of, always doing the 2 or 3 sets of 10. We can also progress multiplanar exercises in the low, for the lower extremity. So maybe we're working more into the frontal plane. We're doing some transverse plane strengthening. We're working the kinetic chain, so we're working on the core and hips a little bit. For some of our older folks that want to get back to something like golf or tennis, I think rotational strengthening is good. And then sport specific drills, we can progress to with clearance from the surgeon. In this phase, we could initiate a return to walking program. That kind of blends well. We talked about this in previous episodes, but I think just because it's a total knee replacement, it doesn't change our return to sport progressions. We still want to think about good strengthening, maybe doing some strength testing, and then going ahead and doing, a return to walking program before we start something like return to jogging. Maybe we're doing some low level agility and, low level, higher volume plyometrics. I think it's okay to do with these folks. You still want to bridge that gap of kind of checking all those rehab boxes to make sure you're not skipping steps. And, I think like you mentioned earlier in this episode, Dan, having someone who comes in and they're back to doing like an aggressive sport, but they haven't done a lot of the things that will make that transition smooth. So this is the phase where we kind of go through, all those good return to sport type activities and make sure we're kind of hitting each of those progressions so they feel as good as they can getting back to the activities they want to get back to. So, at this point, you've nailed all the basics. And now you're really working with the patient on their long-term goals. And you might have patients who say, my motion's full, I feel fine, I'm done with physical therapy, and that's probably okay. And then you have patients who want to get back to certain things. And I think you don't treat these much differently than you treat, someone getting back to ACL. I mean, the intensity of the exercises might be different. The volume of training is going to be different, but the principles are similar. And we want to make sure that we don't shortchange our total knee replacement patients. We can still provide high quality rehab kind of by going through all these phases. So I think this will be a fun phase. And I think, some of the older patients might really like it because they feel like athletes and they're getting back to doing things they didn't think they could do when their knee was really bothering them.
Yeah, I think that's actually a really good point. I had a patient recently and he had a unilateral knee replacement and he has just had a heck of a time. So just kind of bad luck in terms of orthopedic injuries over the course of his life. And he ended up a unilateral, I think it was a patellar knee replacement. And he was squatting for the first time in like 15 years, right? Mm-hmm. Which doesn't sound crazy to the average person, but for someone who's been in pain for so long, it's pretty wild. And he started to open some avenues for athletic things he hasn't done in years, right? So we're trying to progress back to some stepping stuff that was going to eventually get him back to something like tennis. And he had just kind of given up on that. He just wrote off any sort of athletic activity because it was so painful for so long. Mm-hmm. What's kind of cool is that once you show patients what they're able to do, they may kind of catch this bug of like, oh, I want to get more involved with tennis or pickleball or golf, whatever it is. And that's obviously beneficial because the more we can get those folks active, the healthier they're going to be. So that's obviously a beneficial thing. So try not to shortchange this phase of rehab. It's my personal thought. And I'm imagining this is what's going on in most clinics is that you basically see these patients for around 12 weeks. Maybe you see them for another few weeks after that, but insurance kind of runs out and they get kicked to the curb. And then they probably don't get the best advanced phase of rehab. And for the majority of folks, maybe that's A-okay. But for folks that want to get back to a little bit more, they probably need more than we currently give them. And I would say try to imagine they are a bit more like those younger athletic patients and see if you can just be good about criteria-based progression, introduction of some slight plyometrics. We know that these folks have a fall risk. They could work on some light agility drills. So there's a lot of awesome things we can do for these folks. We probably don't just because there's a lot of barriers per se. But if you can go that extra mile, I think it'll really help out a lot for those patients.
And then just kind of summarizing, some key takeaways for physical therapists for rehabbing total knee replacements is, like a lot of other surgeries, we want to use time and criteria to guide our progressions. Range of motion, quad strength, pain, swelling, response to exercise guide the decision-making process. NMES and balance training are really helpful early on and something that I think is good to implement and kind of in line with the research. And then as we progress to later stages, we want to customize the programming to meet the patient's long-term goals. So we want to make sure we have that shared decision-making conversation and kind of see what their end goal is. So we don't just get rid of them when they have full motion. We try to, help them get back to whatever activities that they came to you for and that they want to get back to.
All right. So Kevin did a great job of teaching you guys how to rehab post-op knee replacement patients. But there are still some things to know about knee replacements. Things like, when are they indicated? How long do they last? Am I going to break this thing down by having my patient run on them? We answer all these questions and more. And better yet, this video is living right over Kevin's head. And if you go ahead and click on that, we'll go over what physical therapists need to know about knee replacements. Go ahead and click on it, and I'll see you there.